DARAI for being with us with your lecture, medical and surgical options for endometrioma management.
First of all, we want to thank the Committee of Organization for its invitation to speak on medical surgical management of endometriosis. As we know, endometrioma is the most common lesion of endometriosis. Endometrioma is most often asymptomatic, therefore the presence of symptoms should suggest the presence of other endometriotic lesions. Indeed, as underlined by a red line, in 99% of cases, endometriomas are associated with other lesions. Despite the high incidence of endometrioma, relatively few randomized trials are available to draw definitive conclusions on its management. The main challenge of endometrioma is how to relieve pain while preserving fertility, to define the respective role of medical and surgical management and their combination, taking into account the risk of side effect for each option. In 2017, the French guideline stated that cyclic combined hormonal control decreased endometrioma volume compared to placebo. Another option is the use of progestins with recent data on Dynogest. In the specific setting of endometrioma, few data are available on levonorgestrel intrauterine system. All other medical therapy should be considered second-line option. Recently, numerous studies have focused on the role of Dynogest for managing endometriomas. In our knowledge, this therapy alone is not available in USA, while this option is possible in other countries such as France. Anjoni et al. In 2019 demonstrated that Dynogest alone compared to Dynogest with estrogens have similar benefit on pain, but the advantage of Dynogest alone was to decrease endometrioma diameter after 6 months of treatment, while no impact was found for the group treated by Dynogest plus estrogen. Concerning surgical management of endometrioma, ISHRU recommends to offer surgery as one option to reduce endometriosis-associated pain. Clinicians should take a shared decision with the patient, taking into account preferences, side effects, cost, and availability. Concerning surgical management of endometrioma, both French and ISHRU guidelines do not draw clear recommendations when to opt for surgery in case of pain associated with endometrioma. Moreover, it is not clear how to define a failure of medical treatment. Is there an endometrioma size cutoff? What are the indications in adolescents, in infertile women, and in the premenopausal period? Regardless of these considerations, during surgery, it is recommended to treat both endometrioma and other locations of endometriosis. Concerning technical aspects of surgical management, ISHRU recommends to perform a cystectomy instead of drainage and coagulation in order to reduce the risk of recurrence. Cystectomy and laser vaporization seem to have similar recurrence. Horace Roman et al. Demonstrated the risk of loss of healthy ovarian tissue during cystectomy depending on endometrioma size, with a major impact for endometrioma over 5 centimeters in diameter. Matsuzaki et al. Underlined that treatment was associated with a high risk of removal of normal ovarian tissue during cystectomy, supporting to do not recommend the use. Moreover, Musei et al. Demonstrated the absence of advantage to give GnRH analog before surgery for endometrioma. In a meta-analysis, Raffi et al. Have shown that the mean decrease in AMH serum levels after unilateral cystectomy was 1.1 nanogram per milliliters and reached 2 nanogram for bilateral cystectomy. More recently, UNIS evaluated the decrease over time of AMH serum level after cystectomy unilateral. At 6 and 12 months, the decrease in AMH were 27 and 39.5% respectively, and were 43 and 57% after bilateral cystectomy. When considering only prospective studies, in 2022, the same authors reported a higher decrease in AMH serum levels after cystectomy, but surprisingly without impact on antral follicle count. Another concern on cystectomy for endometrioma is a higher incidence of complication compared to other ovarian cysts. Indeed, Orlando et al. Reported a higher risk of conversion to laparotomy, as well as a higher cumulative complication rate. Another issue is the risk of endometrioma recurrence, reaching up 55% in the theory of Wang et al., depending on the age of the patient and the initial endometrioma size. The risk of recurrence depends also on surgical technique, as demonstrated by ART, with a lower risk for cystectomy compared to ablative technique. Takamura et al. Demonstrated that the risk of recurrence decreased after postoperative hormonal treatment. More recently, Wang et al. Found that the risk of recurrence depended on initial endometrioma diameter, higher for those over 6 cm, for multilocular cysts compared to unilocular, and lower for patients with postoperative treatment compared to no treatment, and especially when the duration of treatment was over 9 months. All this data explain issued guidelines recommending for patients without immediate desire of pregnancy the use of long-term hormonal treatment, mainly based on combined hormonal contraceptive. However, a recent meta-analysis based on prospective trials called into question the dogma of the interest of postoperative hormonal therapy to reduce the risk of recurrence. Another issue is the correlation between the presence of endometrioma and the risk of subfertility. Since 2009, Benaglia et al. Have demonstrated the impact of the presence of endometrioma on spontaneous ovulation, with a decrease depending on the number of endometrioma, even of small size. Issuer recommendation states that fertility preservation should be discussed in women with extensive endometrioma, but as aforementioned, no clear criteria have been suggested. French guidelines recommend to propose a fertility preservation for women with endometrioma, especially with bilateral endometriosis, with prior history of surgery, or for patients with a large endometrioma over 5 cm. Both French and EU recommendations state that there is no advantage to perform surgery for ovarian endometrioma before ART to improve live birth rate, but might be considered for patients with pain or with potential difficulties for ovarian accessibility. In this specific setting, a recent meta-analysis on sclerotherapy found a trend for a higher pregnancy rate after sclerotherapy compared to classic cystectomy. In conclusion, our algorithm to manage endometrioma is based on the initial evaluation of the ovarian reserve by a systematic MSERM levels evaluation with an antral follicle count. Three situations can be distinguished. First, the patient is asymptomatic without immediate desire of pregnancy. We recommend a medical treatment mainly based on diagnosis to decrease endometrioma size, followed by an oocyte cryopreservation. Second, for symptomatic patients wishing to conceive, a laparoscopy fenestration using plasma energy or cystectomy in patients with good ovarian reserve can be proposed, especially in patients seeking for spontaneous pregnancy. After failure of spontaneous pregnancy or in patients with initial alteration of the ovarian reserve, an ART is recommended. Finally, for symptomatic patients without desire of pregnancy, the cystectomy remains an option, followed by a postoperative medical treatment to reduce recurrence risk. Thank you for your attention.
Thank you very much, Professor DARAI, for your lecture. And what we learned that the cystectomy is not recommended for all patients, and we should take care of the age of the desire of conception before deciding to operate these patients. Thank you very much. And the last lecture of the session and of this event will be by my colleague and friend, Dr. Mohamed Zarqawi, our president of the Moroccan Society of Endometriosis and Reproduction. Oui.
On a une deuxième présentation de Dr. Émile.
Ah.
Oui, ça va être lancé.
So we are going to present a second lecture from Professor DARAI. You can go.
It's about salivary diagnosis.
About?
The new salivary diagnosis.
Ah, yes. So the diagnosis of endometriosis by salivary test. It's an exclusive lecture from Professor DARAI.
I want to thank the Committee of Organization of the Congress for the opportunity to present our result on the salivary mRNA signature for the diagnosis of endometriosis. As we know, endometriosis is thought to affect about 119 million of women worldwide, with a major impact on quality of life and on medical burden for the patient, their family, and healthcare system. 2022 issuer recommendation state that endometriosis should be considered in women with the following symptoms, but are often non-specific, such as fatigue, with a risk of overdiagnosis and overuse of therapies. Therefore, there is a need for specific tools to diagnose endometriosis. In this specific setting, several questionnaires have been developed with an insufficient accuracy, as underlined by Surrey and recently by Zondervan. We also try to develop a questionnaire based on a symptom using artificial intelligence with a high accuracy, but a limited value for early stage of the disease. All this data underlines the need to combine questionnaire with other tools. Recently, Pascual et al. In a review of the literature shows the low specificity of clinical history and the wide ranges of clinical examination. In addition, blood markers have a low performance, explaining why issue recommendations do not recommend biological tests. Ultrasound appears relevant for endometrioma as MRI, but with a low performance for superficial and deep endometriosis, especially involving uterosacral ligament. Finally, laparoscopy, despite a high sensitivity, exhibits a low specificity. Despite this data, issue recommendations are to use US or MRI to assess the diagnosis of endometriosis, but with the risk of false negative cases, justifying for some patients the requirement for diagnostic laparoscopy. Finally, with a strong level, 2022 issuer guidelines do not recommend the analysis of biomarker based on endometrial tissue, blood, menstrual or uterine fluids. Since the discovery of mRNAs in 2005, numerous studies have demonstrated the role of small non-coding RNA in both benign and malignant diseases. Biosynthesis of mRNAs includes schematically a nuclear step followed by a cytoplasmic step before interacting with RNA messenger, mainly by a mechanism of silencing. The last step corresponds to the release in the intercellular space of mRNAs under the form of exosome, subsequently detectable in biofluids such as blood, urine, and saliva. Panir et al. In an overview on mRNAs in endometriosis demonstrated the implication of the several mRNAs in various pathophysiological pathways of endometriosis, mainly based on endometrial biopsy, but also in blood or serum, but never on saliva. Moreover, these mRNAs were evaluated using microarray, imposing the second validation by qRT-PCR. However, it is important to note that these two biological techniques allow exploring only a small amount of mRNAs. Mustafa et al. Were the first to analyze on a prospective cohort the expression of mRNAs, including an endometriosis group and a control group with benign gynecological disorder. However, it was not clear how the mRNAs were chosen to build the blood signature. Moreover, it was not clear whether patients, including in the control group, share symptoms suggestive of endometriosis. Initially, using NGS in a prospective cohort with a control group of patients with symptoms suggestive of endometriosis, we demonstrated that patients with endometriosis express all the mRNAs, but with some mRNAs differentially expressed compared to patients without endometriosis, opening new avenues to explore the pathophysiology of the disease. Subsequently, using the combination of two disruptive technologies, namely NGS and artificial intelligence, our goal was to develop a mRNA signature of endometriosis on the discovery cohort with internal validation. The cohort study included 200 patients with symptoms suggestive of endometriosis. All patients underwent both blood and saliva sample. Among the 247 patients, 47 were excluded because of non-meeting inclusion criteria or refusing diagnostic laparoscopy. Among the remaining 200 patients, 153 patients had endometriosis and 47 had no endometriosis proved by laparoscopy. When comparing the endometriosis group with the control group, no difference in epidemiological characteristics was found. All patients had dysmenorrhea. Only a trend for higher incidence of sciatica was noted in the endometriosis group. Using blood sample among the 2,600 mRNAs, a signature composed of 86 mRNAs was developed with a sensitivity of 96.7%, a specificity of 100, and an accuracy over 93%. Similarly, using saliva samples, among the 2,600 mRNAs, a signature composed of 109 mRNAs was developed with a similar pattern that thanks to its simplicity, reproducibility, and feasibility, whatever healthcare availability, we hope to focus on salivary. In conclusion, salivary mRNA signature is an accurate and non-invasive tool to diagnose endometriosis, whatever the disease phenotype. Salivary mRNA signature should be considered the first-line diagnostic test contributing to change the classic algorithm for endometriosis diagnosis. The advantages of salivary mRNA signature are easy sampling, reproducibility, decrease in medical wandering, and potentially decrease burden for healthcare system. However, there is a need for an external validation. Right now, our internal results of the external validation confirm the relevance of our signature. Thank you for your attention.